This episode is based on a true story. Some scenes have been dramatized. Always consult your doctor for medical advice.
Here in the land of two seas, Bahrain, healthcare is one of the priorities in the kingdom. Health, as we all know, is important for human happiness and our well-being. And at Health Hub, we answer your common questions and bring to you information about the advanced medical facilities in Bahrain. In today's episode,
for the past 1 year, I have pain on either side of my stomach.
Crohn's disease is a lifelong condition that affects our gastrointestinal tract. It's a disease where inflammation occurs in the digestive tract, resulting in ulcers, pain, diarrhea, amongst many other problems. The incidence of Crohn's disease has risen significantly in Bahrain from 1990s and up to 2015. I'm Dr. Khawla, and we have dedicated this particular episode to learning more about Crohn's disease.
My name is Sanjeev. I work as an IT manager. For the past 1 year, I have pain on either side of my stomach. And I have been to many doctors, trying to find a diagnosis. So it's mostly mental stress because you are having pain on a daily basis and you don't know what it is and nobody can diagnose what it is. Hi, doctor.
Hello.
Hello.
I'm Dr. Zayani.
I'm
How are
Sanjeev.
you?
Yeah, good.
Please
This is the letter from the other doctor,
Yes.
Dr. Faisal.
Yes. Okay, tell me, what symptoms actually brought you to the attention of Dr. Faisal?
Doctor, I have been having pain on either side of my stomach for the last nearly 1 year. I have been to around 2 other hospitals and they couldn't diagnose it. They have done my CT but I still have pain on both sides. And
Is the pain daily?
It's a daily pain, like when I drive the car, when I'm in the office, the pain is always here.
With this pain, does it wake you up at night?
Not much while I'm sleeping, but it's mostly when I'm sitting, like when I'm sitting like this.
Yeah.
I have constant pain on both sides of my stomach.
What makes this pain worse?
It's like, I think if I eat some specific foods, I think it gets more irritated, but it's like a constant pain. It doesn't go up to a very high level. The pain is a medium level, but it's like very constant.
Okay. Has it affected your weight?
Yes, I had a drastic weight loss of more than 10 kilograms in 45 days.
Any diarrhea?
It's not diarrhea per se, but it's like the stools are not normal. It's
Okay.
like it's in between a diarrhea and a normal stool.
How often you have to go to the bathroom?
4 to 5 times
What about before you got ill? What was your bowel habit like?
daily, like once a day.
So there is a drastic change in the
Drastic
number.
change. Yeah.
Any blood in the stool?
Visually, I haven't seen, but in the tests, the blood has
It shows
been
up.
there. Yeah.
Have you suffered any mouth ulcers, any skin lesions, any joint pain?
No mouth ulcers, but I have joint pains,
Okay.
especially on my left hand. I cannot take this finger up,
So there is.
and I cannot take this finger down. It's like
Is there anybody in your family with bowel disease?
actually my father passed away with a stomach ailment, but it wasn't diagnosed as stomach disease. But they told it's some sort of a cancer. But Now I'm thinking with all this, probably he might have had that and it was in this diagnosis.
Misdiagnosed.
Yeah.
We need to run a few tests to come up with a diagnosis, okay? And we'll do a physical exam first and ultrasound, and depending what we find, I'll explain to you the next step in diagnosis.
Sure.
Okay? Hello again, I'm just going to examine you, and then after that I'll do an ultrasound. It's not painful. It will allow me to see inside your abdomen and see the area of the pain that you complain of.
Sure.
So what I found is that in your small bowel, at the junction between the colon and the small bowel, there is slight thickening in this area and accumulation of fluid inside the bowel. This tells me where I need to focus for making your diagnosis. Okay, I'll let you get dressed and I'll explain to you your next step.
Good morning, Dr. Najah. Thank you for
morning.
having us today. So, Dr. Najah, our topic today is on Crohn's disease. Tell us what triggered your interest in this particular condition.
Well, when I studied in the United States, I was involved in research on Crohn's disease, and that really triggered my interest. I was told by other physicians it is rare in our area, that they did not diagnose cases. But to my great surprise, I now follow up 2,000 cases of Crohn's disease.
So, speaking of symptoms, when should I worry? When should I come and see a gastroenterologist?
Okay, the commonest symptom of Crohn's disease is persistent diarrhea or constipation in children. So unlike adults, in children the presentation may be severe constipation. And in addition to the diarrhea, they experience crampy abdominal pain, urgency to go to the bathroom. If there is small bowel involvement, they may present with vomiting and what we call extraintestinal Crohn's disease.
So if I'm a doctor, a primary care doctor, and I see or I document these symptoms in one of my patients, what should I do to make sure he gets the appropriate care?
First, you can start by screening them, and there is a very good screening test in the stool called the calprotectin. We can screen their stools. If the calprotectin is positive in the stool, that means they have bowel inflammation. And then you contact a gastroenterologist. Luckily enough, in Bahrain, we have many gastroenterologists who are well trained to perform the diagnostic procedures and who have dealt with a lot of cases of Crohn's disease. We have to tell and educate our patient and family of patients that this is a lifelong process. Unfortunately, we don't know how to cure it, but we know how to control it.
And with control, can someone live a normal life?
Absolutely. There are many well-known achievers in our world who are known to have Crohn's disease, and it does not affect the intelligence or the performance of people, creativity of people. It does affect their life quality, making them more focused on their symptoms and less focused on their daily activity.
So how do we diagnose Crohn's?
Based on the clinical criteria and the physical examination clues, the best way to diagnose Crohn's disease is to do an endoscopic diagnosis. But I found out from my experience in Bahrain that about 25% of cases also have stomach and duodenal involvement. So the upper GI tract is often involved, and when you see the same finding in the stomach and the small bowel, as well as the colon, then you can focus more on therapy to improve their nutrition and stop their nausea, which comes from stomach involvement, and you will achieve better treatment.
Thank you, Dr. Najah, for the wonderful explanations. Can we go to the ultrasound?
Sure.
Dr. Najah, tell us about the role of physical exam in diagnosing Crohn's.
Okay, once we get the collection of symptoms pointing towards Crohn's disease, we look for telltale signs on physical examination. For example, we look for eye inflammation, we look for mouth ulcers, we look for findings on abdomen of tenderness or bulging area in the abdomen. We look for the perianal area for any disease, and we look at the skin, because the skin sometimes reflects systemic inflammation and a condition called erythema nodosum, which is nodular, rounded target lesion.
Can you walk us through the role of ultrasound to diagnose Crohn's?
Well, the ultrasound is of great interest to me because I found, with experience of about 2,000 patients, that I can pick up small bowel inflammation and Crohn's disease even before the endoscopy. And the things I look for are, like here, you'll see fluid. This is free fluid.
So black is fluid?
Yeah. This is the bladder, which should contain urine, right? But behind the bladder is a window that will allow me to look at the small bowel and look at the fluid in the cavity of the abdomen, called free fluid.
Okay.
If I find this free fluid and inflamed, thickened bowel, this is almost diagnostic of small bowel inflammation, and we have to confirm it later by endoscopy.
And this does not have any radiation risk,
Not at all.
right? For
Not at
anyone
all.
who's
Not
getting
at
it.
all.
So you can get as many ultrasounds as you need with no risk.
And you can use it as a follow-up. For example, you treat a patient, then within a month you see the patient again, you look at the same area where you detected the inflammation, and you'll see how much improvement there is. You can even measure the thickness of the bowel. Normal small bowel should not exceed 3 millimeters. So any bowel thicker than 3 millimeters tells you it is inflamed or thickened, or what we call edema of bowel.
Yes. What if you cannot diagnose or you cannot find these symptoms on ultrasound? What do you do next to confirm?
Not everybody would have an ultrasound finding for Crohn's. For example, if the Crohn's is in a very early phase, you will not see ultrasound findings indicative of Crohn's disease. Okay? If the patient has had a bowel resection, the area of tightness or inflammation has been removed, you will not detect it by ultrasound. Okay, so ultrasound is very helpful, but the final diagnosis comes from colonoscopy or endoscopy. Yeah.
Would you mind showing us the endoscopy suite and how we do these types of procedures?
Sure.
Very good, thank you. So Dr. Najah, what is an endoscopy used for?
Endoscopy is a technique that evolved between 1958 and now, when doctors discovered with the use of a camera on tip of an instrument, you can enter the gut of patients from inside and take pictures of the stomach, the colon, the small intestine. And as technology evolved, it became very sophisticated. Now we have what's called flexible endoscopes, and they are very comfortable compared to the rigid scopes previously. They're also very of an extremely high definition of images, so you can see details. For example, I'll show you here. We can take detailed images of a fine print. It will show you even thumbprints of a hand in clear detail. The scopes also are equipped with light filters that will allow you to see malignant areas very clearly, so you can target your biopsies. All of this is allowing us to also record live the procedure and show it to the patient, and also have a documentation or record of the procedure.
What do you say, Dr. Najah, to everyone who's very worried about an endoscopy? Is it safe to do an endoscopy?
Endoscopy is actually quite safe. The safety record is, the complication rate is less than 1 per 100,000 cases. If you select your patient properly and you make sure that you have examined the patient is not, for example, suffering cardiac disease or lung disease or has a recent MI, then it is a very safe procedure.
I heard there is an elaborate process after the endoscopy is done to make sure, no infections happen, etc. Yeah. Can you walk us through this procedure,
This
Dr.
scope,
Najah?
after we finish the endoscopy, is immediately We suck water through it to clean the channel, and we put it in a processing box. The box goes labeled as dirty box. So it goes in a box like this. So nobody touches a dirty scope. It is in the box. Transfer this to washing area. In this room, we have what's called the disinfection or cleaning room or processing room of the scope. And this process is manual and automated. So the important step is to for the nurse who's cleaning the scope or the technician cleaning the scope is to do very thorough external cleaning, flush the channels of the scope where the biopsy channel is and where all the air and water runs through the scope, and then after that it's hooked up to an automatic washer. This washer has an automated cycle where the scope is placed, okay, with the accessories and the valves opened and programmed to clean it. And so the disinfected material runs through it in full cycle, soaking, disinfecting, and then flushing the channels. The scopes are then dried, and alcohol and air is pushed through the channels to dry the channels up. This is a very important step to avoid transmission of infection from one patient to the other. The drying is very important. The pre-wash is a mechanical cleaning, which is a very important step. So any debris or mucus is washed, and then it's placed in the washing machine with a fixed cycle using disinfectant solution. It's an endoscopy. After this washing process, the machine will tell you the scope is clean. It is dried, mechanically dried, and air is flushed in the scope in this way to dry all the channels. Okay, and then the scope is hung to dry in this special cabinet. It takes minimum of half an hour to do a washing and drying of the scope, and then the scopes are hung in there and kept in a ventilated cabinet. The cabinet allows drying, and any scope that's been more than 72 hours will be reprocessed again if it's not used.
So this is our reporting station. Can you walk us through the images of the endoscopy?
The system here allows me to save all the images I have captured during the endoscopy in shots as well as video form recording, and all of these images are transferred to the server of the hospital. So I can review them after finishing the procedure, select the best images that show the abnormality, and print the pictures with the report to give them to the patient, as well as a full recording of their procedure.
Can you walk us, Dr. Najah, through a normal first endoscopy or a colonoscopy image so that people know?
A normal endoscopy, the mucosa looks pink to salmon colored. You can see the vessels, so it's very transparent, and this indicates that the mucosa is healthy. It's like glass. So basically you can see the capillaries running across the mucosa very clearly. So this is not an inflamed mucosa at all. This is a normal small bowel, and this is a normal colon. And this is the junction between the small and the large bowel. It's called the ileocecal valve.
And that's where Crohn's can occur.
That's the commonest area for Crohn's. When we finish the procedure, we turn the scope upside down. We call this a retroflex view, so we can see the inside of the rectum. So if there are any hemorrhoids, abscesses, fissures, we can see them in this region. In Crohn's disease, there are basically mucosal, submucosal, or muscle involvement, depending on the chronicity and the severity.
Mucosal is more superficial than
is the inner layer of the gut,
yes.
The very inner layer, like the layer inside your mouth. Okay, and the earliest finding, the most subtle, is this tiny small ulcer, about 0.5 to 1 millimeter in size. Now with the new scopes, as I told you, there is a light filter called narrowband imaging, so allows me to apply a contrast of color, so I'll see this ulcer very clearly there. If I don't look thoroughly and enter the small bowel, I will miss these cases. And Crohn's disease can progress from the very mild to a more severe form of Crohn's disease. For example, this is a more severe form where we see nodularity now, there is swelling and ulcers. So this is the second stage where the inflammation has gone to a deeper layer. Still, this is very mild compared to what other cases will progress. I'll show you now an example of severe Crohn's disease, whereby these are deep ulcers and the mucosa is involved in multiple ulcers, plus it starts involving the muscle layer of the bowel, narrowing the bowel.
Yes.
So we start getting tight areas, the food cannot enter, and the patient at this stage suffers with severe crampy abdominal pain and vomiting if he eats something that will block this area. If we let this progress, we'll end up with a stricture. Stricture means narrowing, severe narrowing of the bowel happens like this, where the food cannot pass at all.
So how do you fix that sort of thing?
Yeah, that sort of thing we can fix with targeting it with a balloon. If it is early and not completely tight and fibrous completely, you can do what's called endoscopic balloon dilation, where I pass a balloon under direct vision into the narrow area over a guide wire, so I'm sure I'm in the hole, not to the side of it. And then I inflate the balloon, putting high pressure, sustaining it for about 1 minute. And then we go gradually, depending. If the stricture is 3 millimeter, I might dilate to 5, then to 7, then to 10. Gradually, you should not do a sudden dilatation. Other things scopes can show are polyps and tumors, and I would like to show you, for example, how endoscopy allow me to remove these polyps and these tumors. This is one example of a patient who had a big tumor, almost occluding the gut, and with the use of injection under the tumor of this blue material, methylene blue, we were able to elevate the tumor and close the hole. And this is after resection of the tumor, and then the whole tumor can be retrieved and sent to histopathology.
So you don't even have to open up someone's belly to
Yes,
take out.
if you're lucky enough to catch it at an early stage, you can really cure these polyps. Hello, how are you? How do you feel after the procedure?
I feel okay.
Good, good. I want to explain to you what we found during the procedure. So this is a sketch of what we did. Basically, we went through the colon from the left to the right to the junction of the small and large bowel.
Did you know that Crohn's disease can affect people of all ages? Symptoms, though, start particularly at a young age and can go undiagnosed for long periods of time. Crohn's can also affect any part of the gastrointestinal tract, from the mouth all the way down to the large intestine and the anus. It can also have some extra intestinal manifestations affecting the joints, the eyes, or even the skin. No one really knows what causes Crohn's disease. Scientists believe it's a combination of genes, maybe even a defect of the immune system, or our own gut bacteria. All of these factors probably contribute to the causation of Crohn's disease.
Anyway, the disease was Crohn's, as they found out. I have been told that I have to be on lifelong medication. So something which you have to take lifelong is a little painful, but still, I'm happy that they found it at least, and I'm under medication now.
The most rewarding thing I would say in my practice is to see difficult cases unresolved, where I end up making the diagnosis and changing the quality of life of patients, and pay attention to their emotional state, not only their health. I get very involved in their healthcare, but also in their social and psychological well-being.
Every week at Health Hub, we bring you the latest and most relevant information to your health. I'm Dr. Khawla, and I'll see you next week.